Somnath from INTAS. So today we have anti-PF4 immunothrombotic syndrome in our Mumbai hematology group. So it's my privilege to introduce So we have for moderation for today we have Dr. Amit Khurana sir. Sir is a fellowship in bone marrow transplant and sir is a renowned hematologist as well as practicing as a hemato-oncologist in Surat. Sir is highly skilled and experienced hemato-oncologist with more than a decade of experience in the field. Sir has a fellowship in bone marrow transplant, hematology, clinical hematology, and is an expert in managing hematological and hemato-oncological patients. Sir has experience in performing bone marrow aspirations, bone marrow biopsy, and other hematological procedures. Sir has extensive experience in both autologous as well as allogenic stem cell transplant. With that, I would hand over to Dr. Amit Khurana, sir, to keep the ball rolling. Sir, please.
Thank you, Mr. Somnath. Well, very good morning to all of you, and good afternoon and good evening to all others who are joining from rest part of the world. Today, our guest speaker for the day is Colonel Dr. Rajan Kapoor from Delhi, and he's going to lecture us on anti-PF4 immunothrombotic syndromes. This webinar, as usual, is brought to you by Mumbai Hematology Group, supported by INTAS, and very well managed by Perfect Square. I thank Mr. Arun Hegde, Dr. Manoj Kumar, and team from INTAS, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group. Our chief guest for the day, Dr. Ajay Bapna from Jaipur. Our guest speaker for the day, Colonel Dr. Rajan Kapoor from Delhi. All our discussants who are themselves very eminent hematologists, and you participants for spending a Sunday morning, afternoon, or evening from whichever part of the world you're logged in. Let me give you a flavor of our next weekend activities. Next Saturday, that is 30th of December 2025 from 7 p.m. Indian Standard Time and 8:30 a.m. US Eastern Time, where Dr. Vaishali Sanchorawala from Boston, USA, speaking to us on advances in the diagnosis and treatment of systemic AL amyloidosis. And the following day, that is Sunday, 14th of December 2025 from 11:30 a.m. Indian Standard Time, we have again Dr. Tajinder Singh from Gurugram speaking to us on in the era of molecular biology, is morphology still relevant in diagnosis of myeloproliferative neoplasms? Let me introduce our discussions for the day, and they are very well displayed over here in alphabetical order. I will pause for a while for you to have a look on all our discussions for the day who are very eminent hematologists, hemato-oncologists, pediatric hematologists, medical oncologists all across the country. So these are our discussions for the day. And now it's time to introduce our guest speaker for the day. We have with us no other than Colonel Dr. Rajan Kapoor from Delhi. Let me introduce Dr. Rajan Kapoor to all of you. He is MD, DNB Medicine, DM Clinical Hematology, Professor and Head, Department of Hematology and Stem Cell Transplantation at RNR Army Hospital, New Delhi. He did his DM in Clinical Hematology from AIMS, New Delhi, way back in 2008 to 2011. Earlier, he did his DNB in Internal Medicine, NBE 2004, and MD in Internal Medicine, APMC Pune, from 2000 to 2003. He is recipient Armed Force Medical Research Committee AFMRC Research Grant and Award for to study genetic polymorphisms of patients of warfarin, Pune 2016. He was awarded Vishistha Seva Mandal Medal for exemplary services by President of India, Pune, India in the year 2014. He also received United Nations Medal for UN Mission Democratic Republic of Congo, Democratic Republic of Congo in 2007. He is also the recipient of Hari Malini Gold Medal for standing first in MD Medicine, University of Pune, 2003. He is Associate Editor of Indian Journal of Hematology and Blood Transfusion. He is also the member, Education Committee, Indian Society of Blood and Marrow Transplantation, ISBMT. He designed software and CRF for data collection from multiple centers for AML and CML, which is being used by Hematologic Cancer Consortium. He has 96 publications to his name, including chapters in books. He has very keen interest in database clinical analytics and development of apps for use of hematologists. His special areas of interest include hematopoietic stem cell transplantation and bone marrow failure syndromes. Today he's with us and he's going to lecture us on anti-PF4 immunothrombotic syndromes. But before he does that, let me introduce our special guest and chief guest for the day. We have with us Dr. Ajay Bapna from Jaipur. Let me introduce Dr. Ajay Bapna to all of you. Dr. Ajay Bapna is Director and Head, Medical Oncology, EMC HRC, Jaipur. He did his medical oncology training way back in 1995-1997 from TMH Mumbai. Then he started Department of Medical and Pediatric Oncology at BMC HRC, the only standalone cancer institute in Jaipur, in the year January 1998. It's my privilege to welcome Dr. Ajay Bapna to inaugurate our webinar and give some words of wisdom. Well, thank you so much. I stop over here. Over to you, Dr. Ajay Bapna.
Thank you very much, Dr. Amit. At the outset, I would like to thank Mumbai Hematology Group and especially Dr. M.B. Agarwal sir for asking me to inaugurate this webinar on anti-PF4 immunothrombotic syndromes. So, it's always a privilege to be part of any meeting of Mumbai Hematology Group, especially which are being organized by Dr. M.B. Agarwal, because he is the fulcrum and person who is the most responsible for creating awareness of hematology across country. And we all have been privileged by attending his various face-to-face meeting and also the various webinars also. At BMCHRC, Jaipur, we also have a very robust medical oncology department and hematology department. And we are the pioneer in starting the CAR T cell therapy at our institute, which we have done in 5 to 6 patients and over 130 or 140 bone marrow transplants also. I also welcome our today's speaker, Dr. Rajan Kapoor. I met him long back when he was a young person at Dr. M.B. Agarwal's meeting. So it's always a pleasure to meet Dr. Rajan Kapoor also. And I'm pretty sure that he will do justice to the topic allotted to him. And I wish him the good luck for today's webinar and also to Dr. Amit Khurana for the today's webinar. Please go ahead.
Thank you, Dr. Ajay Bapna, sir, for that wonderful, wonderful words of wisdom. It truly means a lot to all of us. And
Thank
Dr.
you.
Rajan Kapoor was not young, he's young forever.
Yeah. I met him long back. I think he will be remembering me.
Yeah.
So he
Yeah.
remains young forever.
Yeah.
That kind of personality he has. So, Dr. Rajan Kapoor, the screen is yours. Please go ahead.
Yeah, I'll just try sharing it first and see if it's is it visible?
Very visible. Please go ahead. Full screen mode, please. Yes. Absolutely.
Yeah. So first of all, right now I'm there in Leh. So the words by Ajay sir and Dr. Amit, they have filled me in warmth. The temperature right now is -12, so
Wow.
sub-zero. So that's the beauty of Leh at this time. But thank you so much for all those kind words, especially from Dr. Ajay. I definitely remember you because I also belong to Jaipur. I think I'll meet you next time when I'm there.
Yeah.
And it's
Sure. We'll wait for you.
yeah, absolutely. And it's always a pleasure being introduced by Dr. Amit. I mean, the way he introduces and tells you good thing, it makes you feel and warm. And it's always been a pleasure to be part of these MHG webinars and the conferences because it gives you time to prepare for the topics, and I hope that I'm able to do justice to this topic. So the one thing which I'm going to speak on is I would say a lot of interest has been generated around platelet factor 4, especially the residents who are there in this today. The latest blood article also, which I'll just go and passing it, just published a couple of days back, had two articles on anti-PF4, and not only for the hematologists but for all internists. I would say all internal medicine and especially anti-aging. So this molecule is coming up in a big way. So my topic is for immunothrombotic syndromes, and this is beyond heparin and vaccines. So I'll try to discuss it in pathophysiology, diagnosis, variants, and management. So this is where I am presently. This is a winter wonderland, and I extend a warm invitation to everyone who can weather the cold or the summers to be here. And why I have chosen this picture is right now I'm uh, director of this hospital, and this is one of the harshest terrain and climate which we can encounter. And as you know, the Indian Army, I mean, it's a lot of deployment in this area, and we encounter a lot of thrombosis. Now, in this area, we have thrombosis in young people because all are young soldiers, 20s, 30s. So it always intrigues us why these soldiers who are supremely fit and suddenly they have thrombosis, the venous and the arterial. So in fact, we have just now got approval from an ICMR project to actually look into these factors. So that's why I thought that this is a very pertinent topic for all of us. So why this matters, anti-PF4? So the numbers though are small, but very high stakes, and recognition of this entity is very important because management actually makes a difference in this. And this is a entity which has got both arterial as well as venous thrombosis, and especially thrombosis at rare sites like cerebrovenous thrombosis and the splanchnic vein thrombosis. Now, there are two terms which all residents should understand. One is called immunothrombosis and thromboinflammation. They are two distinct but intertwined, as you'll see. So just to set the context, so two terms which we have, one is called as immunothrombosis, where the first part is inflammation, it overshoots and it leads to clotting. While in the thromboinflammation, it is the first the thrombus which is formed, in the coagulation there is a crosstalk, there is immune recruitment, and it causes barrier loss. The trigger is inflammation or infection. So this is the topic which I have got. This is NTPF4. This is immunothrombosis. While in thromboinflammation, first comes the thrombus and then the immune system is reactivated. So we all know about neutrophil and extracellular traps. So it is antibody dependent. We'll see in detail, and tissue factor protein S exposure. While in thromboinflammation, it is platelet leukocyte coupling, BWF. Why important to know thromboinflammation is a lot of now articles and research is going on areas like stroke CVAs, where they have found that the persons who have a lot of inflammation after thrombosis, they have a poor prognosis. So if you see the examples, CVT, HIT, VITT, this is immunothrombosis. While as I said, if there is a stroke and infarct expansion, the post-stroke neuroinflammation, which is very important for the long-term prognosis, that is thromboinflammation. What are the therapeutic implications? We'll discuss. Now, we know if it is immunothrombosis, we can tackle it. I'll show the examples. While in thromboinflammation, it is very important that you have antiplatelets, but it's very important at what time you introduce antiplatelet and anti-inflammatory agents, and so to minimize the damage due to thrombosis. Now, just a little bit about platelet factor 4. As I said, a lot of interest around this molecules. If you see this hematopoietic stem cells, myeloid progenitors. So if you see, platelet factor 4 is involved in almost all the steps of stem cell proliferation, maturation, and further differentiation into the other lineages. It's a highly cationic tetrameric protein. It's very important, and it is secreted from megakaryocytes as well as platelet alpha granules. It has got a very positive charge. So this is very important when we discuss about the anti-platelet 4 syndromes. So it binds to anions. So the negatively charged, as we all know, heparin is a typical example of very heavily negatively charged protein, and it forms stable tetramers and heterodiamonds. Physiologic role, it does inhibit hematopoiesis and angiogenesis. It interferes with platelet coagulation. So if you can see wherever it is written as negative, it inhibits hematopoiesis, promotes host inflammation, and it is an anti-tumor. So a lot of implication, therapeutic implication of this one. Now, what I was saying today only, I read this paper, which is said that PF4 is the new kit for anti-aging. So though we thought that PF4, as we see in the previous diagram cartoon, that it inhibits hematopoietic stem cell differentiation, but they have said that remodeling of the megakaryocyte niche and PF4 downregulation are the central mechanism in HSC aging. So as we age, the PF4 is downregulated. So somehow if there is a PF4 supplementation acting on LDL receptors, it rejuvenates the function of aged HSC. So there's a lot of research which is going on. How can we increase the PF4 to delay the HSC aging? So very interesting stuff. Now, this was the physiologic role. What is the pathogenic potential? So this is what I am going to discuss in detail. So if you see the timeline, 1973 was the first time the classic hit was explained. It has been known in cardiac surgery. Mainly it was discovered in the cardiac surgery, post-cardiac surgery, where they use a lot of heparin and anions. So they are heparin-dependent antibodies and led to hit. Then 2001, an entity came as autoimmune hit. Again, the trigger was heparin, and they were heparin dependent and heparin independent antibodies. Now, 2008, very interesting thing which came as spontaneous hit. Now, there was no heparin used, and there was a case series which was published which said that after a TKR, now they had a hit-like picture without heparin being given. So they were heparin independent antibodies, basically because of glycosaminoglycans, so which were used in the implants, as well as people were giving glycosaminoglycan supplementation on. And this, we all know, COVID taught us a lot of things, not only COVID, the vaccines which were made. So a lot of noise around whether to take vaccines or not. So a definite entity which was described was VITT, vaccine-induced thrombotic thrombocytopenia. There are heparin-independent antibodies. So if you see this cartoon, if you see the platelet factor 4, as we had said, it's a highly cationic, it forms a tetramer. If there are heparin-dependent antigen sites, so they are poles. They bind on the poles. We call it north and the south pole. While there's an equator where we have a heparin binding. So heparin-dependent glycosaminoglycans or other antibodies would bind on the poles, while the heparin binds in the equator. So if someone asked, this is a very nice review which came in 22, the 4 anti-PF4 disorders. If you get a question on that, so there is a classic hit, which is heparin dependent. Triggers are heparin. Low molecular weight heparin can also trigger, and certain other drugs. Probability of thrombosis is 30 to 70%. And when you do PF4 dependent enzyme immunoassay, which is an ELISA based assay, it is positive, it is a screening test, and the platelet activation test. So we'll come to that, how to diagnose it. So they are positive in it. When we talk about the autoimmune hip, it can be dependent or heparin independent, again by heparin, can be due to fondaparinux also. Here in autoimmune is a highly thrombogenic. So you have more than 95% will have thrombosis, and they are positive for these tests. Then there is an entity spontaneous hit, which is seen in TKR. Again, highly thrombogenic. Same way with VITT, adenovirus vector vaccines, is positive. So now why very important is VITT, where the probability of thrombosis is more, even the mortality and morbidity is much higher. So again, there is a review by Muller et al. With anti-PF4 immunothrombosis, again, which we have already explained. PF4 tetramers are usually distant from each other due to charge. So they are highly positive, they repel each other. However, whenever any polyanions, as we had discussed earlier, the heparin binds on the equator, they charge the neutralization. So the repelling charge is neutralized, and high avidity antibodies can overcome repulsions. So classic hit without heparin, no immune complexes. With heparin, there is immune complex formation. Same way in autoimmune, if you can see, again, the immune complex formation is there. While in VITT, this is a different entity. Again, there are immune complex formations. Important thing to understand is that in VITT, it is the adenovirus which is triggering the immune complex formation. So this is a cartoon which actually with whatever understanding I had, I made it. So just to have clear understanding for myself, I hope it is useful for the others also. So there is a trigger, polyanion, which bind PF4, heparin, LMWH, vaccines, sometimes bacteria where there is spontaneous hit is there. So there is a PF4 tetramer. There is a change, conformation change. So as we had seen, the new epitopes, the cations in the poles or the equator, the new epitope exposure is there. So around 5 days it takes, and it forms anti-PF4 IgG production. These are the antibodies. Now these immune complexes form on the vascular cell. It can be PF4 polyanion IgG or PF4 IgG. Now, what do these do? They cause the injury to endothelium. So one of the mechanisms is endothelium injury. PF4 binds the VWF, complement and leukocytes are recruited, or it can activate the neutrophils, as we had said, in neutrophil extracellular traps which are found. The PF4 binds these nets, PF4, NET, and IgG scaffolds are formed. Third thing is the monocytes. FC gamma receptor is activated, tissue factor is increased, and the microparticles are made. And the fourth is platelets. Phosphatidyl serine exposure is there. Then microplatelets, as we know, are more thrombogenic. So if someone has to understand, immune complex cause 4 injuries: endothelium, the neutrophils, monocytes, and the platelets. And all of them have a positive feedback. More platelet PF4 release, more complexes, amplified thrombin burst, and there it leads to the clinical phenotype. It causes consumptive coagulopathy leading to thrombocytopenia and prothrombotic DIC-like state. So this in nutshell is the whole pathophysiology of anti-PF4 immunothrombotic syndrome. Now, there was a nice review again, which we had referred to earlier in seminars in hematology. So anti-PF4 is prothrombotic, and it actually behaves like a DIC state. So if you understand the DIC state, we have DIC at one spectrum is hemorrhagic, which we classically seen in ICUs. They have bleeding. So this is the one you have aortic dissection, trauma, obstetric, envenomation, primary fibrinolysis. They were primarily present with bleeding in hepatic failure. On the other spectrum are these disorders which are predominantly prothrombotic. So it is anti-PF4, idiopathic purpura fulminans, pancreatitis, then we know the antiphospholipid syndrome, the transplant rejection in the cancers, and then there is a mixed pro-hemorrhagic and prothrombotic. So if you understand, all these disorders are form a prostate of, you can call an immunothrombosis. So immune system and thrombosis are intertwined so closely that we have a mix of bleeding at one spectrum and thrombosis at others. Now coming to what is the epidemiology and the clinical burden, why it is important for all of us to know. Hit 0.2 to 5% in heparin exposed, 50%, as we had said, will have thrombosis. It can be venous, arterial, or both. And onset is day 5 to 10. We all know the classical 4 T's, which we have been taught for diagnosis of HIT. Second entity is VITT, which is ultra rare. Someone saying that we should not. That time there was a lot of debate whether actually the current US president was also drawn into that debate. We all know that, but it is ultra rare. But it's very important to diagnose in time, because almost actually 70%, some papers have said almost 95% will have thrombosis, CVT, and splanchnic, and young females are at risk. Variants, as we had discussed, post ortho surgery, we can have a spontaneous hit-like picture. Now, these are very interesting topic which we'll discuss as a hematologist. Chronic MGTS is monoclonal gammopathy of thrombotic significance. So now plasma cell dyscrasias, we keep on having new entities. So this is a relatively new entity, not MGUS, it is MGTS. Important thing is, if you do not treat MGTS, it is 30% mortality. I'll come to this entity. And then there has been a links to stroke, DVT, pregnancy loss. Why I'm telling this is, whenever you see a thrombosis at atypical site, or a thrombosis which is not responding to the usual antithrombotic agent, please keep this entity in mind. Now, when we talk about acute anti-PF disorders, what is the lab pattern? The easiest and the screening test whenever you suspect is an ELISA-based assay, which picks up high titer IgG anti-PF4 antibodies, which is very high in it. Then in specialized lab, I think not all labs can do it, but there are functional assays. The commonest is a serotonin release assay, heparin-induced platelet activation, and PF4-induced flow cytometry based platelet activation, which is recently introduced, but is highly sensitive, and it can be done wherever there is a flow cytometer. Now, SRA and HEPA, 70 to 90% release at low or no heparin, then it is hit. PF4 enhanced activation for WIT. So VITT, there's a new specific test is PF4 enhanced activation. Now, the rapid assay, like the ELISA assay, are useful in HIT, but important thing is they have very low sensitivity for VITT. So if you are suspecting VITT, if ELISA is negative, don't rule out, because VITT is a diagnosis. A clinical suspicion is very important. That important thing is, in VITT, DA dimer is often markedly elevated. It is very, very high. And like in DIC, fibrinogen can be low in VITT-like states. So classically, when we talk about HIT, we say that PT, APTT is normal and fibrinogen is normal in HIT, but in VITT-like state, fibrinogen can be low. So that can be a clinic for a clinicians awaiting specialized test. If someone has a history of a vaccine, atypical thrombosis, D-dimer is very high and fibrinogen can be low. If fibrinogen is low, please suspect VITT. Now, the other entity which is not usually described, recent one, is a chronic anti-PF disorders. So this is an MGTS, monoclonal gammopathy of thrombotic significance. So they have a low but persistent anti-PF4 EI positive. So very weak positivity of ELISA. Don't rely too much on ELISA. Functional assay remain positive for a very long time, but this is very important. Monoclonality. SPEP and IFE may show low M spike, and we'll discuss that paper which came as a seminal paper in an NEJM about this entity. We did a purification, it confirmed anti-PF4 monoclonal IgG. Very fantastic science which they had used. They picked up an M spike and anti-PF4 monoclonal IgG. If you do a mass spectroscopy, it shows IgG often lambda light chain. So this is very important. An elderly coming with a atypical thrombosis, it is prudent nowadays to get a protein electrophoresis done, because if you pick up a M spike, it may be a monoclonal gammopathy of thrombotic significance. So, this is a diagram again, which I tried to make from the various articles. So, if you have a typical EIA cutoff is 0.4 if the issue is the optical density. acute, if there is a acute thrombosis, acute PF4, it decline by 7 to 16 weeks. So if you see 7 to 16 weeks, they will be non-detectable. But chronic one like MGTS and VITT may show low OD with ongoing functional activity. Why this is important is, supposingly you have picked up, it's always important to repeat the ELISA based assay, because if it is going on for a longer time, please remember, these are the pathologic antibodies, so thrombosis is going to continue for a longer time. So this is a timeline diagram. No, so if you have to compare the acute versus chronic, so acute has high optical density more than 2, while the chronic has a low and persistent. Functional assays are strongly positive. They are positive, but not that strong, often heparin independent. Rapid assay hit is very sensitive. VITT is very poor. Both of them are acute, but VITT cannot be picked up by the ELISA. Chronic may often they are negative. Confirmation is by standard ELISA was functional. Here, chronic, we should have mass spectroscopy for clonality, which is not available in most of the labs. This is transient, maybe reversion in weeks to months, but here in chronic, these antibodies in case reports have persisted for more than 1 year. So you should know anti-PF4 has acute, which is hit and VITT, and chronic is MGTS and again VITT like. So how do you monitor and resolve acute hit? Functional assays are often negative, as we had seen in the diagram, by 50 days. Immunoassay negativity median by 85 to 90 days. In acute VITT, functional activation wanes over weeks. Anti-PF4 may persist longer. And so it's very important to know that once the functional assay is negative, then a subsequent vaccination can be done. However, I would admit that it's very difficult. If someone has developed a VITT, I would be very scared to give another shot of the vaccine. Chronic MGTS is, you have to monitor them by serial ELISA and functional every 3 to 6 months. Always track the D-dimer is raised and the platelets. Plan long-term management. And I'll come to this. What do you do when you have an MGTS? When should you do advanced techniques? If you have the chronic VITT, it's always important to contact centers of excellence where they do these tests, like a mass spectrometry where you can demonstrate the monoclonality, you can do epitope monitoring, you can do quantitative optical density interpretation, higher OD predicts activation, dilution can unmask VITT. So these are the special tests which can be done in the specialized labs. Now HIT, I heard about HIT. We'll just give a case scenario. So there's a 45-year-old. It's a real time which we had faced. So ischemic cardiomyopathy on unfractionated heparin, it develops a 50% platelet fall by day 7 and a new DVT. We know the 4T score. It was 7. PF4 ELISA was positive, SRA positive. There was no doubt in the diagnosis acute HIT. Immediate actions, stop all heparin and start non-heparin. So we had fondaparinux. We started that. We didn't have access to bivalirudin at that time. Now please remember, he remains unstable. Now, the basic thing, the cardiologist is after you that he will require invasive cardiac procedure soon. What should you do? He has a HIT. You cannot give heparin. You're starting on fondaparinux. What should you do? This is a challenge for a consultative hematologist. I'm sure many of us has faced this problem. Now, in a cardiovascular surgery, please remember there are certain pitfalls. So HIT has been made, I would say, very favorite diagnosis of all when we are called for. Please remember, after early post cardiopulmonary bypass, there may be thrombocytopenia. So thrombocytopenia without HIT is also common. So it is 30 to 50% fall can occur within 48 to 72 hours. So teaching point is, look for a biphasic fall. First time, it should not occur before 5 to 10 days. If it is occurring within 2 to 3 days, unlikely to be HIT. Digital ischemia, you'll think that it is thrombosis. Please remember, this ischemia is often due to the pressors, lines, peripheral vascular disease, not HIT. So this is a very important thing which all of us have, is called as anchoring bias. So if you are on telephone called so and so after cardiac bypass, he's got ischemia, he's got thrombocytopenia, you have already made up your mind that it is hit. So when you go and land up at the patient by its side, you always try to fit in all the parameters which suit your diagnosis. This is called anchoring bias. Avoid anchoring bias so that you don't misdiagnose. High seroprevalence post-op. So please remember, PF4 antibodies are common without HIT. So I always teach my resident, test for these HIT antibody only if you have very strong pre-test probability. So that's what is a base theorem. So please, because if you say thrombocytopenia, digital ischemia, and you do an ELISA, it is positive, you'll label it as HIT. Remember, that patient requires heparin because of cardiac condition which was in the first place. So if you tell them you cannot give heparin, you cannot give fondaparinux, it's going to be very detrimental. So again, this is what I have made. Phases of it, this is very important why they matter for surgery. So there is an acute hit, then there is subacute hit where the functional tests are positive. Then subacute hit B, we call it alpha when the functional test is positive, and we call it bravo when the function test is negative or antibodies are positive. And remote hit is function when it is negative and EV is negative. So if you see these the x-axis, you see 20 days, till 20 days it would be acute hit would be over and it would go into hit A. By 40, by 2 months it would be B, and then it is remote. So platelet recovery typically 7 days, functional test negative by 50 days, and antibodies often disappear by 85 days. Why it is important is that in this table we'll tell that if it is an acute, platelets are low, functional assay is positive, immunoassay positive, delay surgery. It's very difficult to do surgery in heparin. Now, subacute hit A. Now, platelets have recovered. So, clinically, platelets have recovered. This functional immunoassay is positive. You avoid heparin, but you can consider direct thrombin inhibitor if you have access to biovalidine. If surgery is life-saving, don't deny it. Because functional assay may be positive, but platelets are recovered. Keeping fingers crossed, let them do the surgery. Subacute B, when we said functional negative, immunoassay is positive, heparin can be used in this intraoperatively. So this is very important. If we go back to this is the time period. Earlier we used to say, no, please don't do any surgery. A person, if a cardiothoracic surgeon says it's life-saving, you can give intra-op if your functional test is negative and platelets are normal. Remote, again, intra-op acceptable, but pre and post still we don't give heparin, give direct thrombin. We have, I'll come to that, direct thrombin inhibitors which we can do, and monitor platelet. So this is very important as a consultative hematologist to know HIT and the phases of HIT to decide on surgery. So to summarize, if acute, subacute A and cannot delay, bivalidine if you have available, you can use intra-op. The other thing which we did in that patient is you can do therapeutic plasma exchange, IVIG, and give heparin. So subacute A means platelets have recovered. You give a plasma exchange, IVIG, and heparin because bivalidine is not freely available. So we did this and the patient did very well. If it's later, you can give very potent antiplatelet also and can use heparin. So for subacute B or remote, intra-heparin is acceptable. Avoid pre-post heparin and monitor platelets. So this is very important how you manage and day-to-day clinical practice. So post-operative, all of us know we use fondaparinux, but if you avoid if there is a renal failure or weight is less than 50 kg, apixaban and rivaroxaban are two new agents which are now available to us, which can be used in a HIT in a post-operative. Intraoperative, of course, you cannot use these oral agents. So these rivaroxaban, hepatic impairment, you have to have caution. So this is important. So HIT, again, this chart which I have made, which may be of use to residents if they have. So if you have a hit, calculate 40 score, intermediate, high probability. If it is no, please don't do hit ELISA if your probability is low. If it is yes, stop all heparin, start non-heparin anticoagulant. If he is stable, you can use apixaban, rivaroxaban, which we have started using it because bivalirudin is very difficult. Order for ELISA functional assay, high OD ELISA and positive functional, yes, confirm hit, continue non-heparin, avoid platelets unless life-threatening bleed. Platelets are contraindicated. If thrombosis, anticoagulation for 3 months. If there is no or weak evidence and negative functional, hit is unlikely, reevaluate. So if there is a discordant strong ELISA but negative functional, considered atypical hit, then you go for a specialized lab and you can consider IVIG if severe or refractory. So please remember, hit management, not only stopping hit, but if surgery is required, IVIG, thrombotic plasmapheresis can also be done. So this is typically seen in orthopedic surgery, spontaneous hit. So again, we had a 50-year-old female, post TKR, day 6, platelet are 60,000, and she developed dyspnea and confirmed to have pulmonary embolism. 4 Ts was 6/8, ELISA was positive, SRA 60, rule out. Management is very important. Stop all polyanions, any glycosamine glycans, whether it's oral or in the implants or something, check for that, stop it. Start fondapanex by rivaroxaban. If it is persistent, you can do rituximab. In this patient, the resolution was week 4. By 1 month it was, and there was no recurrence. So please remember, have a high index of suspicion. They can occur without heparin, especially in TKR. Again, this is a case which we had published. 35-year-old female, day 10 post-Covishield, severe headache, platelet 40,000, cerebral venous thrombosis, 4 Ts, again adaptive one, high probability. Anti-PF4 was not very high. D-dimer is very markedly elevated in VITT and low fibrinogen. So before, if your ELISA is negative, but D-dimer is very high, low fibrinogen, suspect VITT, started on IVIG, fondaparinux, steroids, platelets increased by day 3, full recovery. So please remember, I mean, now probably we won't see much, but I am not very sure many other vaccines can also cause it. So remember, IVIG is a lifesaver in these conditions. Unusual site, rapid diagnosis is important. Heparin is contraindicated in VITT. So again, this algorithm for VITT, 5 to 30 days post adenoviral, platelets, D-dimer very high, fibrinogen low. If it is yes, treat now. Very important, don't wait for the test. If you're suspecting, treat. So you give IVIG, avoid platelets, replace fibrinogen if it's very low, then you can order for tests. If it's yes, then you can steroids, plasma exchange can be done if it's severe. Anticoagulation for 3 to 6 months. So these are all very evolving fields, so the treatment is not well documented, but the bottom line is treat first. So I always think that in VITT, mortality is very high, so treat first, test later. Now I'll come to this. This is a very seminal paper which came VITT-like monoclonal gammopathy of thrombotic significance. Why I remember this? Because I had done a CPC some time back with a PGI Chandigarh case, and ultimately the person died, and the diagnosis was MGTS. That time we did not know this entity, but now the papers are coming. So this is what they had discussed, 5 patients. So if you see, varying starting from 35 to 79-year-old, both males and females. So duration of illness was 4 years. There was one mortality. If you see the platelet counts in 2 patients, it was 44 and 50, but all of them had thrombocytopenia, and 2 of them had CVT. So these were the cases which had been discussed in this paper. Now, this was the patient 1, which I want to explain. This is the one patient. He had 60-year-old and he did not have CVT. So if you see why it's important, 60-year-old coming earlier with arterial thrombosis, hepatic vein, DVT. Now they was on LMWH, they had undergone thrombolysis. Then someone thought of, you see, after 850, I mean, almost 3 to 4 years, someone thought of doing a positive hit screen. Then they started giving IVIG, and when they gave IVIG, you see the platelets had come up, and then they tested for anti-PF4 antibodies. And long and short of it, and the diagnosis was made, and a person survived. Now, the patient 2, I think, is the one which died. Now, why I've chosen these 2 patients? Because this was the one where he was never worked up for MGTS, because this entity was not known, but you can see multiple thrombosis, DVT, recurrent, superficial, adrenal hemorrhage, DVT, again DVT, despite anticoagulation. When they had hit screen, tried to give something, but he had persistent thrombocytosis. So what we learn from these cases, unusual site thrombosis, recurrent thrombosis despite anticoagulation, try to do a hit screen. If there is positive or even negative, maybe there's a case to look for a monoclonal protein. So this is what the thrombotic sites were there. They had DVT, all of them had DVT. So earlier, I mean, even now we see when someone has DVT, we keep on getting protein C, S, antithrombin, and all those tests. I don't think so. They make more of a difference. But this is an entity which makes a difference. If someone has a DVT and we are not fine, please do suspect this anti-PF4 antibodies, and in elderly or even in young. It's a very simple test to get a protein electrophoresis and immunofixation done. And if someone has both venous and an arterial, it definitely makes a case to walk you down. Again, this one, just to say what tests were done, they did ELISA, then platelet activation test. All of them were strongly positive. So if someone has recurrent thrombosis, ELISA is positive, functional assay is done, and all of them had N protein, which was discussed. So this is why it is important. So these are the 2 entities, MGTS and post-viral, as we have said, chronic IF4. So this is positive. Again, it's very strongly positive in NGTS while it is positive. And the main discrimination between these 2 is the M protein is present or absent. So chronic recurrent thrombosis, do anti-PF4, do an M protein. If it is present, it falls in the category of MGTS, or it could be a post-viral VITT. So without vaccine also they can develop. Again, it's chronic. Most of the viral VITTs are acute thrombosis, as we had said. Normally they have thrombocytopenia in both, and M protein is a differentiating factor. Now, this is very important. In patient 1, when they were able to diagnose, they gave IVIG, ibrutinib, no further thrombosis. So this life was saved. Here, in patient 2, only anticoagulation was done and he died. 3, they did IVIG, plex, rituximab, myeloma therapy, remission, and no thrombosis. Again, here, rituximab, ibrutinib, IVIG. So why I'm showing this is, many of us in our clinical practice actually have seen patients like this who had recurrent thrombosis, and unfortunately we're not able to save them because we never thought of these things, because this entity was not described. But however, now if we diagnose, we can use myeloma anti-B cell therapy, ibrutinib, IVIG, and anti-myeloma therapy. Like in patient 3, a DARA-based therapy was given and doing fine. So please remember, anticoagulation alone is often inadequate in these conditions. High dose IVIG is transient benefit. BTK inhibitors do platelet response, and bortezomib DARA can go in MGTS. So key takeaways: MGTS explains most chronic of anti-PF disorders, recurrent thrombosis, intermittent thrombosis. It's a red flag. Even faint protein, less than 0.1, can be pathogenic. They cannot be MGUS. If there is thrombosis, it is MGTS. Go for PF4 assay and electrophoresis, IVIG, BTK inhibitors, cell therapy. So this is what I feel is a question. Whenever there is an MGUS, always assess a thrombosis risk. I think it makes a case, if we find a case of an MGUS, look for maybe, definitely get a Doppler and look for a thrombosis. And probably maybe we have to see with the wider availability of ELISA based assay and functional assays to look, because this may be fatal. Another thing which came in again NEJM is pregnancy loss. Again, there is an eye opener for me. Monoclonal anti-PF4 antibodies, it is associated with recurrent pregnancy loss too. So it can be in young and can be bad. So this is again the two cases which they had, 42 and 37 had. So any case thrombosis with thrombocytopenia even in pregnancy, it makes a case to do an anti-PF4 profile. And if you do, one of the patient had actually a monoclonal spike also. So it's important that these are the new entities in recurrent pregnancy loss also to be taken. So laboratory insights is in the chronic things, standard protein electrophoresis negative, mass spectrometry, no MGUS, but they had picked up anti-PF4 antibodies. This was not MGTS. So they had antibodies and platelet activation were inhibited by high dose heparin, FC gamma blockade, and IVIG. So key implication may contribute to recurrent pregnancy loss. PF4 specific enrichment assays are, again, standard anticoagulation is insufficient. IVIG in refractory cases, so like maybe a larger study. So I'm sure if we look for it, we'll find more. So this is again a diagnostic flow for MGTS. Recurrent thrombosis, standard thromboscreen negative. Yes, then test for PF4, generally strong. If there is functional assay, if it is yes, because both PF4 and functional assays are positive in MGTS, screen for monoclonal protein. Management is continued anticoagulation, but please remember anticoagulation alone is not enough. You may have to give IVIG, rituximab. If it is refractory, BTK inhibitor, plasma exchange, then you monitor. More important is once the ELISA and the functional assays are positive, you have to monitor for years. Again, this is a very interesting paper, this which came in, they had just picked up DVT patients, which we see so commonly, and they found that PF4 levels were elevated. PF4 triggered net formation via autophagy. So this anitosis, which we call, increases the tissue factor fibrinogen. So again, this is important, and there is a common garden DVT. If you're not finding any cause, it makes a case to test for that. So DVT in anti-PF4, immunothrombotic, and classical, what is the difference? Classical, generally you have a trigger where it is spontaneous platelets. So whenever the platelets are low in DVT or any thrombosis, please suspect that. So that is the take-home message which I think. So what is the research potential? I'll just say what I am doing here. We have picked up so many cases of thrombosis here where I am right now in the high altitude. So we have found a lot of MIs, DVTs, and mesenteric ischemia in young people. They are all 25, 30, 35 years old. So we are looking at, this is the ICMR project which we are going to do. This is, we have a hypothesis that hypoxia causes endothelial injury, inflammation. It increases PF4 and increases NETs. So this is a paper which came, the NET markers elevated. So we are also going to be looking at these NET markers. So altitude hypoxia may amplify PF4 NET thrombosis excess. So APS cases may, anti-PF4 cases may be unmasked at altitude in young soldiers or trekkers. So let's see what the results come, because it's got a lot of implications for the national security also when we have these young soldiers in a high altitude. So we are doing thrombosis cases with anti-PF4 testing. Probably we'll be able to answer some questions in the coming years. We are going to explore the PF4 autophagy and etosis pathways and screening strategies for recurrent unprovoked thrombosis in young at high altitude. That is our plan. So to conclude, anti-PF4 key models for antibody-mediated immunothrombosis, thrombocytopenia and thrombosis, consider anti-PF4. Anticoagulant refractory thrombosis, consider anti-PF4. Chronic forms linked to monoclonal gammopathy, which is called as MGTS. Anticoagulation, please remember, it alone is insufficient. You have to have therapies like IVIG. Recurrent thrombosis and chronic neurovascular complications. With this, I have ended. I'll just try to finish. I hope I didn't overshoot. I guess
That was brilliant. Thank you so much, Dr. Rajan Kapoor. That was a fantastic lecture.
Thank
Super.
you.
It was an eye opener for all of us.
For me, actually, it was quite an eye opener preparing for it, because I thought many of the cases probably could have diagnosed if we knew about it.
Thank you so much for a wonderful, wonderful lecture. Now I request all our discussants to please put the hand raised signs so that we can start our question session with Dr. Rajan Kapoor. Yes, Dr. Asha Shah, ma'am, please go ahead.
I have a question that in all these disorders where it is not a HIT syndrome, the one important feature is that the fibrinogen is low, which helps in the diagnosis. When you have a VITT-like syndrome, which is not heparin dependent, fibrinogen is low. I wanted to know, in addition to IVIG, plasma, pheresis, what are the indications for fibrinogen correction here? At what level and at what timeline?
Right, ma'am. So, as you had correctly pointed out, VITT, so there are no correct guidelines for fibrinogen replacement as such. But as you had pointed out, D-dimer, if it is very high, and fibrinogen, I mean, the study which they had shown, if it is less than 100, normally in DIC we take it as 200, but less than 100, then it makes a sign. Now, the problem here, we do not have a recombinant fibrinogen which we have in the West. So here you may have to give plasma FFP, you may have to give, or a cryo too, if you are having a refractory VITT. So if you have a refractory VITT, you have a thrombocytopenia, it's not recovering, and fibrinogen is low, you can give a cryo as we do it in DIC. But clear-cut guidelines I'm not aware of, because it's a very rare reported entity, but they have used recombinant fibrinogen also in some papers.
Would it not be like a double-edged weapon also, because there is thrombosis also?
Yeah, thrombosis, but that's what, if it is not responding. So the first line is IVIG. So as the case which I had shown, we have given IVIG 1 gram per kg for 2 to 3 days. Actually, here you can go up to 3 grams per kg total. You do a plex, you do IVIG, most of them would respond. But if the fibrinogen continues to be persistently high and the thrombosis is there, then there's no point, because platelets are out, heparin is out, that is contraindicated. So the only factor which is remaining is a cryo, which we can use. No set guidelines.
Thank you.
Thank you, ma'am.
So fibrinogen correction is must.
Not must. So as we said, generally we give IVIG first, and plex not responding, fibrinogen still is very low, then there's a case for giving fibrinogen. Like one case which I had seen, we had not used fibrinogen or cryo. Any experience someone has, I mean, I'd be ready to think, but we were not, we are not used, but it's mentioned that you can use fibrinogen if it is very low, not described what level as such.
Regarding you said about spontaneous hit because of knee replacement surgery.
Yeah.
Knee replacement surgery itself can cause DVT.
Yes.
How can you differentiate from spontaneous hit versus versus the knee replacement surgery causing DVT?
Yeah, so same thing. Even in spontaneous hit, you use that 4T score. So supposing after surgery, there is a thrombocytopenia. So any DVT generally does not have. So any DVT which is causing thrombocytopenia after surgery, I might take for all clinical, this thing is thrombocytopenia coming, suspect, then get an ELISA done. If that is there, then I guess.
Dr. Rama, can you please mute yourself? Dr. Rama? Dr. Rama, can you please mute yourself? Yes, sir. Please go ahead.
So my clinical thing for everything is thrombocytopenia. If it is coming with the DVT, do suspect an PF4, and we can get those ELISA-based assay, which are commonly done, and functional assays in a specialized lab. I am sure in each big city we have those to confirm. But the bottom line, what I have seen from clinical practice is, like you said, spontaneous or even the cardiovascular. Clinician and a clinical history is very, very important. If your pre-test probability of hit is low, don't test for it. Means, as I had shown in examples, it's very common to have thrombocytopenia due to many reasons. As you said, DVT is also very common, digital ischemia is common. But if you think that it is not hit clinically, don't test for it, because sometimes it is false positive, ELISA, and it may be detrimental to health, especially in a cardiovascular. You deny a heparin to someone who deserves it, then also it is going to be detrimental. So, as you pointed out, clinical before you order for tests.
One more question is that if the patient is already diagnosed as HIT, after how many days he can receive heparin again?
Okay, so that's what I had shown in that diagram which I had made. So there are 4 phases of hit. So one is an acute hit, then there is a subacute, which is in A and B, and the chronic hit. So the clinical pointer is once the platelet starts recovering. Once the platelet starts recovering, that means it has gone into the subacute stage. You test for functional assays and immunoassays. If functional assay is positive, that is subacute A, and once the functional assay is B, negative, it is subacute B. So subacute B would come around 2 to 3 months after 60 days as such. So as a clinician, if your platelet activation, platelets are normal and your functional assays is negative, you can safely use heparin intraoperatively. But post-op, don't give heparin, use apixaban or rivaroxaban. So that is the key message which is there. So you should know the phases of it.
Thank you so much. Dr. Shilpi, your question, please.
Good morning, sir. Thank you for the enlightening lecture. And especially the algorithms that you gave on HIT, VITT, and MGTS. Hats off to you sitting at such a high altitude and minus 12 degrees Celsius.
And with hypoxia affecting my brain.
Yeah, I could make that out. So, in such a under-discussed topic, sir. Sir, my question is, I just wanted to confirm, basically, you have already mentioned in the lecture. So, in elderly people with atypical site thrombosis, do you recommend to do upfront M spike?
Yeah, absolutely. Because this is a test which is freely available and can be done. Atypical site thrombosis, and obviously you do your routine, I am saying thrombosis, like cancer screening and other things which we all do. But this should also form a part of a workup, definitely.
My second question is, sir, in recurrent pregnancy loss, so that anti-PF4 profile should also be done upfront?
This would be too early to say, but this is the seminal paper which has come in NEJM. Okay, so if there is a recurrent pregnancy loss and there is no other cause found, but the most important clinically, if there is thrombocytopenia. So if there is a recurrent pregnancy loss and thrombocytopenia, so as we teach to all our residents, thrombocytopenia, rule out antiphospholipid syndrome, rule out SLE, TTP. So if that is not ruled out, then definitely. So if you have a point, if there's no thrombocytopenia and pregnancy loss, then I don't think so we should chase that. But if there is a thrombocytopenia, then I think it makes a case to rule out these entities.
Okay. Thank you so much, sir. Thank you, sir.
Thank you.
Same holds true for MGTS also?
Absolutely. No, absolutely.
Without thrombocytopenia, it won't be.
Yeah, it won't. But my take is, since whenever elderly comes with thrombosis, as it is, we do cancer screening. I mean, it's like we check for cancer screening. So it does make a point that you should do an M-band also.
M-band positive, no thrombocytopenia.
M1 positive, no thrombocytopenia also, we should, then probably it would fall. If you have ruled out other causes, then again it would fall in MGT. Then you can go ahead with anti-PF4 and functional assays also, if M-band is positive. So because M-band, because there's a recent paper with I think Vincent Rajkumar, where they had shown the monoclonal this thing MGUS and other things, where they have mentioned this entity of MGTS. So they also have mentioned if there's an unusual site thrombosis in elderly, it makes a case for checking for M-band. If M-band is, why it is very important, because a lot of therapeutic implications. You pick up, you start anti-myeloma therapy or ibrutinib, as we had seen in those cases, they are alive. And you keep on giving anticoagulation alone, they are not going to make it.
True. Another question is from Dr. Kannan. If the patient is previously exposed to heparin, can HIT occur earlier?
Absolutely. So that HIT, as he pointed out, generally 5 to 6, it will occur. On the re-exposure, it would definitely occur within 1 to 2 days, definitely. So that is always there.
Thank you. Another question from Dr. S.K. Sharma. In light of MGTS awareness, would you suggest testing all monoclonal gammopathy or unknown significance cases for PF4 to know whether they are thrombotic risk in future?
Yeah. So that I had mentioned 2 question marks, but I'll come back to what your suggestion was, that if there is an MGUS with thrombocytopenia, then definitely we have to do it. But MGUS per se, as of present guidelines, they all have to be assessed for thrombotic risk. Anti-PF4, obviously no one is recommending that, but if they have other pointers like thrombocytopenia occurring, then definitely, or the D-dimer is going up. So there are simple tests which we can do. CBC obviously will be doing. So if there is thrombocytopenia and D-dimer is high, please, I think we should work up for anti-PF4.
Thank you. So can we stick to the flowchart for even APLA? Because in APLA also we have thrombocytopenia.
Yes, absolutely.
APLA negative, then go ahead.
Absolutely.
Yeah. Because that question was asked from Dr. Kannan also. So first, why can't we think of APLA first and then go?
Absolutely.
So Dr. Neemath Handa, your question, please.
Thank you, Dr. When should we, I might have missed some points. I want to clarify that when should we start PLEX and HIT?
PLEX
When
and
should we
HIT.
consider PLEX? Yeah.
So PLEX in HIT, as I had shown in the algorithm, generally it is in the refractory. So the first step, whenever you are suspecting HIT, when you have a pre-test probability, the first thing is you stop heparin. Heparin in all way, in all flushes and everything, wherever the heparin. And if you have an access to, if the patient is stable, we now start on direct thrombin inhibitors like Apixaban, Rivaroxaban, that can be started. If they cannot be given, if you have access of bivalent. But despite stopping heparin and giving direct thrombin inhibitor, if there is the thrombosis is increasing, say there is a fresh site of thrombosis or thrombocytopenia is worsening, say normally in HIT it is around 70-80, if it is worsening, then definitely there is a case to start IVIG and PLEX, both in refractory cases. But most of them probably would not require IVIG or PLEX as such.
Thank you, sir.
Thank you, Dr. Thanda. Another question from Dr. Akanksha. Which unusual site of thrombosis would you like to screen when you're suspecting VITT or MGTS?
So cerebral venous sinus thrombosis and splanchnic vein thrombosis. These are the 2 major sites where you have, or a combined venous and arterial. Again, just recently blood advances, they have said a person on say DVT on anticoagulation, if he has an arterial stroke, then definitely you should be looking for it. But unusual sites, the 2 commonest are the splanchnic and the CVST, cerebral venous sinus thrombosis.
So in splanchnic vein thrombosis, we usually screen for mainly 3 things. One is myeloproliferative neoplasm.
Yeah.
Second, we are doing is PNH by FLAIR.
Yes, absolutely.
And third, we do APLA testing.
Absolutely.
4th thing should be your screen for PF4.
PF4, yes, again, the rider is if there is a thrombocytopenia, it makes a stronger case for doing PF4. But as you had pointed out, these three, so definitely, and if you don't find any of these things, so you don't, PNH, everything is negative, then definitely it makes a case for testing for these things.
And if it is positive, then how long the duration of anticoagulation should be?
Okay, so NT-PF4, if it is positive, then the next step, whenever ELISA, then you do a functional assay. So if the functional assay, and supposing you are not found any MGTS or any other disorder, so the guidance to therapy is by the functional assay. The minimum anticoagulation is for 3 to 6 months. Anticoagulation, and you keep monitoring the functional. If the functional assay remain positive, then it becomes a chronic anti-PF4, then you will have to give a long-term anticoagulation. But here, if the functional test become negative, then you can stop anticoagulation, but the monitoring is required. And as I had said, it's still a very evolving and a recent things which are coming. So no clear-cut guidelines, but they have said 3 to 6 months in all cases of VITT, as well as HIT with a direct thrombin inhibitors, and monitor the functional assay. So that is how we do it.
Because functional assays are not easily available in.
Absolutely. So 6 months. So I my practical take, I mean, I won't manage. Practical take is monitor the platelet counts. So monitor the platelet counts if they are improving, and if you supposingly have done a D-dimer, the D-dimer has settled down, and in VITT the fibrinogen levels have gone up. So if the fibrinogen levels have gone up, platelets are normal, D-dimer is normal, give minimum 6 months of anticoagulation and monitor. So that would be the most practical thing which you can do.
Thank you. Another question is from Dr. Akanksha. If the patient has been diagnosed as MGTS, how would you go about this? When to start with myeloma-directed therapy? Straight away?
Yes, absolutely. So if MGTS, I presume that the individual must have had thrombosis. So if they have thrombosis, then only we diagnose as MGTS. If MGTS is confirmed, then the 3 therapies which they have mentioned, if there is a acute thrombosis which is going on, IVIG, and if there is a severe thrombocytopenia, then ibrutinib. So they have given BTK inhibitor and IVIG for that. But if thrombosis has been there and platelets are not falling down, and then they have used daratumumab and bortezomib based therapy. So MGTS needs to be treated, because MGTS can be fatal, because the next thrombotic episode may be fatal. So MGTS is not like MGUS that you don't treat, but MGTS will have to be treated like a lines of myeloma. Again, I say that this still an evolving field and there are no set guidelines, but whatever paper that Vincent Rajkumar and the algorithm which I said, it does warrant treatment. Acute thrombosis, ongoing thrombosis, IVIG, BTK inhibitors, once they have settled, start an anti-myeloma therapy.
Thank you. Dr. Rupam Dekha, your question, please.
Sir, in these cases, do you also recommend screening for microangiopathic hemolytic anemias, because that can also cause thrombosis with thrombocytopenia, and an active search for cystocytes, or maybe in suspected cases Adam's 13 levels? Do you recommend them, sir?
Absolutely. So, which I had algorithm, which I had shown the DIC, these are the formifrost, all of them. So, whenever there is a thrombosis and thrombocytopenia, we always look for APLA, we look for HIT, means and we look for TTP, then VITT and these cases. So, whenever there is a thrombosis and thrombocytopenia, as I said, clinical importance is very important. The peripheral smear, look for schistocytes. So, and look for fibrinogen, look for the test and rule out. So these all disorders are intertwined. So that's why they are called as immunothrombotic syndrome. No longer thrombosis per se, but immunothrombotic syndrome. So we'll have to look for, if there are a lot of schistocytes and the setting is right, there is thrombosis, arterial thrombosis, venous thrombosis, thrombocytopenia, a lot of schistocytes, LDH is very, very high. Obviously, you'll be looking for ADMTS and going for TTP.
Thank you, sir.
Thank you, Dr. Rupam Dekha. Dr. Avinash Singh, your question, please.
Yes, nice talk, sir. And
Thank you, Avinash. Thanks a
so
lot.
two things. So For refractory hit, should we wait for, suppose we have started direct thrombin inhibitor, then we should wait for new thrombus, or how to define, or how long to wait before starting IVIG, plasma exchange, or other therapy? So
So
anything?
one of the markers is like if the platelet counts are not falling down, then you know that if the platelet counts are falling down, then definitely you know that it is getting consumed. So you have to monitor the platelet counts very. If the platelet counts are going down, then definitely IVIG and Plex will have to be started. But if there are no fresh thrombosis and your D-dimer is not going up and the platelet counts are stable, then you can continue only with the direct thrombin inhibitors and wait and watch. But yes, if platelets are going down, then it's better to start early IVIG and Plex.
Second thing, any role of steroid, because IVIG in private is very costly and plasma exchange has some issues. So any other cheaper alternative?
Yes, steroids have been used, and I'm sure, but I'm not very aware of the results as such. But steroids we do use, yes. In spontaneous hit, I shown that steroids are definitely used, and in hit also steroids can be used definitely. But they obviously steroids take a longer time to act. But if you feel that a person is likely to go down, you can see the clinical scenario that going down, then definitely. Now the hit, what I see is most of them we see in the cardiac surgery or surgical scenarios. So once we stop heparin, not flushes and direct coming, most of the cases are whatever I feel. So any experience you want to share, any case or something which required a prolonged treatment?
So actually, I'm unaware about the steroids, whether it will help it hit.
Yeah,
Because
that's what I'm
longer
not.
time, and I don't think so whether steroid is going to really help
So
me.
as it is, we are seeing a very low incidence. I mean, nowadays, I sometimes feel that we tend to overdiagnose also hit because we have been grilled so much times. So we have to be very cautious. And yes, as you said, most of the times when stopping heparin, starting on earlier, we didn't have these Epic 7, Rivorex 7. That was the time, and we didn't have bivalirudin at any time. So that was difficult. But now, if it's a stable patient, generally starting them does.
So thank you, Dr. Avinash Singh. There is one question from Dr. Hitha B. What is the treatment for recurrent pregnancy loss with anti-PF4 antibody positive in subsequent pregnancy?
As I would say that this was to kindle interest in the audience that this entity also enter. I have personally not managed. So these are the only 2-3 cases which have been reported, and they have said about IVIG. So IVIG is one thing which they have used. I'm not aware of any treatment guidelines. I'm sure as we see more cases, the guidelines will come. The IVIG was given in these 2 cases. The NEGM report has reported 2 cases, and they said about that IVIG treatment has to be given and monitored by anti-PF4, because if it is still high, they also have said that if the titers are still high, they don't recommend pregnancy as such, because they are at risk of thrombosis at other sites also.
Thanks. So if we can document, then because many patients do come up with recurrent pregnancy loss.
Yes. So this is evolved. Yes.
The medical team we are very clear that that's why. Another question is from Dr. Chirag. Once your anti-PF4 antibody is positive and patient is symptomatic for hit once, so we don't have SRA available, and so we cannot test for SRA to be negative. So if it has to be negative, then you can re-challenge your heparin once again. So when your SRA is not available, can we go for indefinite stopping of heparin? No more re-challenges anymore?
Okay, so you're absolutely right. If there is a hit, please remember why patient was given heparin in the first place. I'm just saying if it's a cardiac surgery, if they don't require heparin, obviously avoid heparin anytime. Don't give heparin at any time. Whenever they require, you give a direct thrombin inhibitor. So, but if your if the scenario is that the cardiothoracic surgeon says that he has to operate, say he has to put an implant and he has to give some kind of an heparin, that is the time when if you don't have a serotonin release, then monitor the platelet counts. So the best is to monitor the platelet counts, monitor the D dimer. If it is stabilized, then and it's say totally unavoidable, I mean the surgery has to be done and heparin has to be given. What we generally do is then you do a plasma exchange, IVIG, give intra-op heparin, give a very strong antiplatelets, and post-op don't give heparin. Heparin can be given only intra-op. If there is a history of hit, heparin is obviously, if it is avoidable, don't give heparin. But if it is unavoidable, give only intra-op, no post-op heparin or LMWH should be given to these guys. So give a very strong antiplatelet agents during the thing. We have the antiplatelet agents and give direct thrombin inhibitors. And that's the way, I mean, the middle path is that, because sometimes it is unavoidable. I mean, the surgeon would say that we have to operate and we have to, because bivalirudin is not available. I mean, I'm not very sure if someone has used bivalirudin or something, because that's not used. And during surgery, you can't use oral apixaban, rivaroxaban. So you give intra-op heparin can be given, provided your platelet counts are not. If platelet counts are low, obviously you cannot use heparin. So that's a practical tip.
Thank you. But if you're documented anti-platelet factor for antibody negative by ELISA, can you again re-challenge?
Yeah, you can re-challenge. You can re-challenge, but again, re-challenge only during intra-op period. I mean, that's the thing. Heparin should not be given as a post-op thrombosis risk. This thing only intra-op.
Thank you. Another question Dr. Chirag has is, where is SRA available in India?
I mean, I know about Delhi. We used to do it in AIMS and Gangaram. I'm sure in Bombay they must be doing in release. Say,
I had no idea, because in Mumbai I don't think so.
Achha.
Anybody has any idea?
I'm not very sure about that, because there they used to, but yeah, as you would rightly say, we only rely on ELISA. That is the most, and you see the cutoff in CMC, because there was one test with the flow cytometry they were saying, because Dr. Sukesh Nair, when you were discussing, I think they were doing that as a research testing, but most of us are relying on the ELISA, but that's very important. That's why it's stressed upon. Your pre-test probability should be very high for it, but because sometimes you ask for ELISA, it will be positive, and that will be labeled as hit. Sometimes we have seen these mislabeling also.
True. Thank you. Another question, Dr. Silva, again, repeat question. If in patients who have got recurrent abortions and now pregnant, you have labeled it as MGTS, how would you counsel the patient? Would you go for prophylactic anticoagulation? Number one. Would you go for prophylactic IVIG therapy in these patients? Number two.
Yeah, so I'm sorry, I will admit that I don't have clear-cut answers for that, but anticoagulation and an IVIG therapy is what for a anti-PF4, because MGTS, I'm not very sure which has been reported in pregnancy as such, but anti-PF4 with the recurrent pregnancy loss, and they have recommended IVIG and anticoagulation. But they have said that anticoagulation alone is not. So as it is in recurrent pregnancy loss, most of the patients are on anticoagulation, heparin. So there is no contraindication for heparin in this particular subset. But IVIG definitely will have to give, but there is no clear-cut answer. And I'll try to read up more, because but this was a very recent thing which I read. I don't have an answer for this.
Thank you. Another question from Dr. Kannan. Can we use put the patient on 6 months of fondaparinux in place of direct thrombin inhibitors?
I really don't think so. That's an answer, because one is that it's in the hit cases, probably he means after as a long-term anticoagulation.
So basically, once diagnosis hit fondaparinux, yes, we can use fondaparinux. But we should switch over to the oral, right?
Yeah, oral ones are much more easily available, cost effective, and I guess similar efficacy. So fondaparinux, I think, has gone out of repute, because earlier we used to use fondaparinux more often because there was no availability of DTIs. Now DOACs are there, so I guess DOACs would score over Fondaparinux. On the rare cases are maybe if there is I mean, again, Fondaparinux cannot be used in renal failure, so there is no advantage of that. So I really don't see a case for a long-term Fondaparinux as such.
True. Thank you. I think I have finished all the questions from the audience. Any discussion want to ask any other question?
In any case, if someone is keen on these algorithms which I made, I can share if it's of any use.
Wonderful flow chart.
So if anyone is interested, then I can share those. I mean, I probably forward it to the mail, and that can be done if it's of any use. Yeah.
So there are no more questions from the audience, and no more hand raised signs. Thank you so much, Dr. Rajan Kapoor. Wonderful lecture, fantastic discussion, and an eye-opening lecture to all of us.
Thanks a lot. I'm looking forward for your hematocon. All the very best. I'm sure your hands are full, but with your organizing capabilities, I know we are going to. As every Olympics and football cup, we see the elevation. So I'm sure Ahmedabad also.
That's giving me pressure now.
Not at all. Thank you so much.
Thank you so much, sir. Thank you. Bye.